Our next speaker is Dr. Kimberly Cockram from Stockton, California.
Thank you to the organizers and panel. This is a good one. It's not as hard. So I have financial disclosures, but they have nothing to do with what I'm speaking on today. 65-year-old Caucasian woman presents with painful, slow, progressive visual loss. Her past medical history is remarkable for the fact she doesn't remember much of her past medical history. She's an extremely poor historian, and she thinks she's on ethambutol because she was told she has tuberculosis, but she's not exactly sure why. She's been on the ethambutol for about 3 months. She's unsure of the dose, and on the second visit she has to bring in her bottle so I can figure out what she's doing. She's on hypertension. She knows she has high blood pressure, but does not take medication currently. She's been told she's diabetic, but she doesn't take medication currently. She denies pretty much everything, but you get the sense she's not totally telling you the truth. One thing she loves to chat about is she's an avid gardener, and she loves gardening so much she's always out in the dirt. And she took a job at Home Depot where she is the person who checks people out. And I asked her, I was like, so at Home Depot you're checking people out. Where do you stand? Because I go to that same Home Depot. She's right where all the pesticide fumes are. So she denies any family history, but she denies pretty much everything. She has no known drug history, and the rest of her review of systems is, of course, negative. So she's seen by 5 different eye care providers. So I'm in Stockton, that's the Central Valley of California, where I call it the third world of California. So the patient has a Medicaid-like product, and so she's not seen by eye care providers that are doing testing on her. She has been told to stop her ethambutol by one of those providers, but because of her poor insurance coverage, she's not gotten any workup until finally her vision starts getting worse and worse and worse, and she's sent to the emergency room, which is the only way that people are managed with Medicaid in California. And there she has a CT scan, non-contrast, 5 millimeter cuts, spiral CT, and she's told it's normal. On examination, she has 2400 vision when I meet her, and definitely has an afferent pupillary defect. She has optic nerve pallor at this point, but my colleagues tell me that at one point she had optic nerve swelling. She has a dense central defect and extensive nerve fiber layer loss, as demonstrated on the OCT. So what would you do next? You can do an MRI, lab assessment, lumbar puncture, imaging of her chest, because she might have had tuberculosis. Would you repeat her workup for tuberculosis?
25. Kim, what was her vision again? I'm sorry.
2400 in the involved eye.
And the other eye?
20/25.
And you said the color vision was normal?
Color vision's poor, visual field's abnormal, dense defect in that eye. The other eye is normal. So everybody says the correct question and answer is we're going to image her. So what are we looking for? So she's got slowly progressive unilateral visual loss.
As was said earlier, we know that she has an optic neuropathy because she has a relative afferent pupillary defect. So we're not going to be worried about the retinal issues that they were earlier today. And it's slowly progressive. And unilateral, slowly progressive visual loss with evidence of an optic neuropathy is some type of compressive lesion until proven otherwise, and you can't prove it without imaging, and the imaging really needs to be MR rather than CT in most cases. The only issue is you threw in this little issue about somebody said she had disc swelling before the atrophy. So then the issue is, do you look more carefully at the orbit, which is more likely to give you a anterior compressive optic neuropathy, or may it be intracranial? And obviously, I would look at both areas to be sure.
What about the pain with eye movement? Would that also push you more towards orbital imaging?
Theoretically, but I don't know. Given the rest of her problems with history, I'm not sure that I would take that.
So the patient had an extensive lab workup eventually, but everything turned out to be normal. It turned out she never had tuberculosis, still unclear why she was placed on ethambutol. She did have some granulomatous changes, but in the Central Valley of California, there's extensive allergens, so a lot of people have these nonspecific nodules. But the CT scan revealed an apical lesion. So this is the CT scan that was done and read as negative. Panel, have you ever seen a CT scan read as normal?
Never.
Not with a big red arrow.
So this case is important because, as I said, I had numerous colleagues in my area who just went with the reading, right? So they had their printout, and the printout said nothing there. So they just followed her from, at the point of her presentation, she was 20/30, they just followed her as she lost her vision. So note to self, if you don't know how to look at a CT, if you can get a colleague to look at it, just double check it, because this is demonstrating an apical lesion with the positive red arrow sign.
Yeah, I'm not trying to defend the radiologist, but I hope the radiologist was told specifically where to look, and not just said patient has headaches or some rather amorphous diagnosis.
Actually, all it said was visual loss, and it didn't say which side. So our colleagues in radiology, they're scrolling through, and they scroll through, hundreds of images. And so it's not unusual that I get referred somebody where they had an imaging study done and it was visual field defect, not helpful, or double vision, not helpful, or even visual loss where they're not specifying the side. So everybody's busy. So what's her clinical course? Well, as you can imagine, she's so cooperative and so helpful, she refused steroids. And she kept working in the garden and kept working at Home Depot, and she returned 8 weeks later, and now she has no light perception, and she has a new motility disorder. Panel?
What were you going to treat with steroids? Were you presuming it was inflammatory at that point, or or is it just, I can't cut it out, so I should try something?
Yeah, that's pretty much the way I do everything, yeah.
No one should go blind without a course of steroids.
That'll come up in about 15 minutes.
Neil, I remember you telling me that a number of years ago, and I quote you always. Yes, no one should go blind without having high-dose steroids.
Given the title of this section, I think it's worth commenting on, why this shouldn't have been drugs or bugs. Right? Such a unilateral presentation, which if it's not ischemic inflammatory and it's slowly progressive, it's always going to be a compressive lesion. I guess hereditary optic neuropathies occasionally, particularly labors, can be unilateral, but in a systemic exposure or systemic nutritional, and there were other things about this that weren't right for nutritional, but I think generally you should expect insidious bilateral for toxic things except for amiodarone, and for bugs, yeah, I guess syphilis could have asymmetric presentations, but generally there's findings in both eyes.
The audience wants to know, what about fungus? After all, she is a gardener.
Yeah, I think that's a good point. In fact, when I was looking at my notes on this case, one of the things I put down was question mark fungus. I think that is certainly still could be something, although it's awfully slow.
Sorry. And the two fungal or families that we think about usually are mucor and aspergillus, but this would sort of fit the bill more for aspergillus, sort of that smoldering kind of clinical course. So she's clearly now got an orbital apex syndrome because she's got this third nerve palsy and she's got optic nerve involvement as well.
One nice thing about a CT in this is that if it is a fungus, you would expect there to be involvement of the paranasal sinuses, and CT will show you that a lot better than MR. One of the issues that I think, and Kim, you touched upon this, as general ophthalmologists, you're dependent on the radiologist when you order an imaging study, and I don't expect general ophthalmologists to go down to the radiology suite to look at the studies themselves, but I do think that if you're concerned about the lack of a process, that you believe there may be a compression, the least you can do is call the radiologist and say, are you absolutely certain there's nothing there? Or get your friendly neuro-ophthalmologist to do that for you.
So moving along, so
So
now we
how long is the course now, or it's a total of months now, or weeks?
months.
Months.
Yeah, so this has been going on at this point approximately 9 months. Next step,
No systemic cancer?
she doesn't know anything about anything.
So Neil raised a great point about the paranasal sinuses. I think you only showed us one sagittal red arrowed scan. Do you have more images that we could look at? Because maybe the ENT doctors would be very helpful here in terms of trying to get some diagnostic biopsy.
So back to the audience. What would you do next? Lab assessment. We already did a lab assessment and it was normal. Lumbar puncture. IV steroids. I love IV steroids. Now an MRI to better define not only the sinuses but the extent of inflammation, or a multi-specialty evaluation as suggested. And the survey says MRI. See if it'll go forward. It's not going forward, guys. There we go. Okay, so an MRI revealed what? What are we looking at now? Is it still just in the orbit? No, it's in the brain, right? You can see the positive red arrow. So that's extensive infiltration of the cavernous sinus in addition to the orbital apex. So what are we dealing with now?
Same thing we were dealing with before.
But
Just
more,
more obvious.
More.
more of the same.
I'd still like to see the paranasal sinuses, if only because the cavernous sinus is a really difficult area to biopsy. But if there was something in the paranasal sinuses, your ENT colleagues could do that. And actually, I think this is one of those where both are right, the repeat imaging, but also a multi-specialty assessment.
So the sinuses were normal. Any additional comments?
Well, just in terms of the orbit, was there, I mean, did the lesion grow in the orbit that maybe it would be accessible now by a lateral orbital approach? It looked like it was just back at the apex before.
No, it remained just at the apex and spread into the cavernous sinus.
So this is a tough one because that's the apex and the cavernous sinus are difficult to get to. It's not that you couldn't, but it's a big deal, especially in this particular patient. There was some pain on eye movement, as Judith pointed out, but is that enough to call it an inflammatory process and push for steroids to see? So it's not a thambutol toxicity. It doesn't give you a mass effect, and it's not GCA or trigeminal neuralgia. So the real issue goes back to how hard do you push for steroids versus going ahead and get some tissue.
Yeah, and certainly I would think, as I alluded to, looking for a metastatic source would be another important space-occupying lesion that could travel this quickly from apex or be in the apex and the cavernous sinus. In my head, I don't distinguish. I think nonspecific orbital inflammation and Tolosa-Hunt syndrome are probably on the same spectrum, and that unfortunately you can't make those diagnoses easily in somebody who's not a great historian, who can't characterize the evolution of a painful, the right number of days to get worse kind of problem that would clearly bucket it into inflammation. So,
but even metastatic or primary cancer can cause a painful ophthalmoplegia.
absolutely. Right.
So Kim, because of time, can you want to tell us what
Absolutely.
happened?
Let's move it along. So this patient went on to agree to be on steroids, responded to the steroids with improvement in the motility, but of course she remained no light perception. What's really weird is she went on to have involvement on the contralateral side. So basically, she marched over the course of just over a year from apex to cavernous sinus to apex and lateral rectus. So we were able to biopsy her. There was a biopsy of the lateral rectus performed that showed non-granulomatous inflammation. There was fat necrosis, which was kind of odd, and she tested positive for glyphosate.
Never heard of it.
Any comments from the panel?
There have been television commercials recently for people on Roundup who might have developed lymphoma, but I hadn't heard about an inflammatory process.
What was odd about her is, first of all, that she was bilateral. That's weird for Tolosa-Hunt. But also the fact that she had persistent imaging characteristics. So typically Tolosa-Hunt, you treat them with steroids and it melts away, both the symptoms, signs, and also the imaging. What was interesting with this is the patient self-activated, that it did the testing herself, and ended up leaving Home Depot and stopped gardening, and at that point, we were able to get her into remission. So, just interesting.
One of the things I think is important is that you can have symptomatic improvement without a change in the imaging. And so I always think that if I'm going to treat somebody as was treated here, I would want more than just the clinical improvement. I would want to look and see if the actual lesion disappears. If it doesn't, again, I'm going to be thinking maybe I better biopsy
Again.
again.
Do you want to summarize, Kim?
So in summary, we have a 65-year-old woman who presented with visual loss. The CT was missed, and the patient went on to have cavernous sinus, and then not only orbital apex, but the muscles involved on the contralateral side. Tolosa Hunt is a very rare condition, but it is something you need to be aware of. So it has decreased vision and dysmotility along with pain, and it's treated with steroids. Thanks so much.
Thank you.